So, good morning, ladies and gentlemen. I'm Mris from ADC Jakarta. I'm a secretary to ADC Jakarta. On behalf of ADC Jakarta staff, we welcome you all to the ADC Jakarta webinar on sports science, on biomechanic and physiotherapy. And before we start with the class with Mr. Joerg Teichmann team, so we would like invite Pak Ria Lumitwarso as ADC Jakarta Director to give the opening remark. Please, Pak Ria Lumitwarso, time is yours.
Thank you very much, Ria. Don't forget everybody, because we have two Ria in ADC, so make sure who you want to call. Maybe me, Ria, or maybe Miss Ria. So make sure it's don't mix up. Good morning, everybody. Very happy to be here with you all, and I hope you will be enjoying with this webinar, because we invite all the professional people to join with us to give us knowledge and experience regarding the biomechanic and physiotherapy. So, of course, before we start, I would like to give little information about ADC. I think some of you come with our name is Regional Development Center, but these years we changed to Area Development Center Jakarta. So before we start the course, I would like to share with you our program for ADC this year. So the first objective of our program is to strengthen the world athletic lecturer. So as you know that we have lecturer in our system, coaches education and certification system, technical official education system, and also the supporting knowledge like now we have. So we make sure that we have the quality to handle future education system because of this condition. So again, that we have the pandemic situation that we never know when will be ended. That's why we have to set up the future education system in order to respond to what athletic planning education. Then we have to ensure that all athletic member, coaches, technical official, administrator, or sports supporting team always in touch with knowledge of athletics. This is a very important point that we invite you now in this webinar. And the fourth one is developing member federation, administration, and management skill. So that means we need to maintain and even to develop our all member in athletic family in always to develop the knowledge and experience. We already start actually the programs. It's in June. We have World Athletic Lecturer workshop for future education. Was 8 to 9 June. Then we have also the strength and conditioning course for World Athletic Lecturer, the 19 to 20 June. We have 70 CSS lecturer. Now we have already many lecturers in our area. And we have World Athletic Technical Official webinar. This after the coach, we invite the technical official. So I think will be complete. Then after that, we have women technical official. And we have communication and marketing webinar for the women. And now we have webinar for sports science. The first webinar for sports science is now sport biomechanics and rehabilitation, 30 to 31st August. So it will have also youth coaches course in September. I think this early September or in the middle of September. We invite the lecturer from our region, and we will invite also the coaches from our area. So we have another 4 activities. The 8th webinar for training programs. It will be end of September, and webinar for sports science. The second one will be the sport nutrition. So World Athletic from the headquarters, Monaco, will organize gender leadership seminar, but we will share to the people in our area. Then the last but not least, incorporating with the member federation, we organize the coaching course and also technical officer course like strength conditioning, sport science, youth coaches, and technical official. So every federation has to organize this kind of course or seminars to have a cooperation with the ADC. We will support you with the certificate and all the material that you need. But I think this will be doing by the member federation and with their lecture. So now, before we start, I would like to welcome Mr. Joerg Teichmann in this Biomechanics and Physiotherapy seminars. Mr. Joerg Teichmann is the founder of Rehabilitation, and I don't know actually the Rehabilitation, but Mr. Joerg will be explain to you what is the Rehabilitation, and head of reconditioning and rehabilitation. This is very important stages. And National Sport Institute of Malaysia Podium Program in 2016 to 2018. Head of Sport Rehabilitation Center, National Sport Institute of Malaysia, 2011-2015. And National Sport Council of Malaysia, 1997 to 2011. So I think this is our first expert. And the second one is Dr. Kin Yuen. This is consultant orthopedics and trauma surgeon in Gleneagles Hospital, Kuala Lumpur and Subang Jaya Medical Center. President of Malaysia Association of Sport Medicine, MESM, and Vice President of Asian Federation of Sport Medicine, AFSM, and involved in professional training and course for postgraduate, undergraduate, and nursing paramedical. And we have the also another expert here, Ms. Rachel, is the rehabilitation therapy, sport therapist for National Sport Institute Malaysia, and head of sport science Rehabilitation Malaysia. So welcome to our expert. Very warm welcome, and we're very happy to have you all here. And I think we will have a very good time in 2 days. Our schedule will be today from 15 to 10:30. We'll be have Mr. Joerg Teichmann, Dr. Chan, and Ms. Rachel. So I think this is just my short speak in this situation, and I'm very happy to have you in this station. And thank you very much for coming, and thank you, Joerg, and your friend to come here for our behalf. Thank you very much, and I give the time back to Ria.
Okay, thank you very much, Pak Rial Mintuarso. And before we start with the class, we would like to announce some rules during we conduct this seminar during we are on the class. So first of all participants should wear the tidy and casual attire. No smoking. And please stay on video mode. Microphone is on mute mode. If you would like to interrupt, you can unmute and mention your name and your country. And then please write your name, not your device brand. So we know each other who you are. So please, if you use the device brand, please rename your device, or please inform us so we can do it from our side. And a particular time, we will ask the lecturer to stop for we are making the photo shot. Please understand that this is our control of the attendance. So make sure that we are stop the class and make a photo shot. You are there. Okay, thank you very much. And now we give the class, we give the time to Mr. Joerg and the team. Pak Joerg's time is yours. Thank you.
Thank you very much, and good morning, everyone. Yati, hello, Malaysia. I can see you very well. Good to see you. By the way, this is Dr. Chan, so we are here already in the office. Looking forward. So first of all, thank you very much for ADC to invite us. Yeah, it's a great pleasure to help you out with this great course, and we was thinking how to do this. First of all, I want to come back to Rehabilitation therapy. Yeah, I was working in ISN and then opened my own center and find a good name. And when I did my internship in Germany in '91 in a center, the name was Rehabilitation. So I called the guy, old man already, and I asked, can I use your name? He said, yes. And Rehabilitation means actually, Reha in German means rehabilitation, and mate is medicine. So these two words come together, and that's it. So it's very simple. Yeah. So a little bit about the 2 days. First of all, I will talk for 5 minutes, and then I give over to my good friend, Dr. Chan. We know each other for a long time, and it's a great pleasure to have him here. And I guess you can benefit a lot from him. And then you have to work with me for another 2.5 hours. Yeah, and we have a lunch break from 12 to 2, when I'm not mistaken. Yes. And then I see you again from 2 o'clock to 4. Yes. So a little bit about my background. I studied sports science. I came to Malaysia in '97, and also in rehabilitation, and they asked me also to coach in Malaysia. So my athlete won the bronze medal in the Asian Games. So I'm quite happy. The high jumper Luke Hamsi, maybe some people still remember him. Quite proud of him. So the good one for me is every time I can talk to all of you. I can talk to the doctors and understand them, and I can talk also to coaches and understand them. And this is a very good, call it connection for me, what is going on, because sometimes as a coach, you have some difficulties because you don't know what's going on with your athletes, nobody inform you, all these things. So, and it's good that we have this course, and we want to say the most important thing, and this is a take-home message for everyone. Guys, when your athlete is injured, he's not sick. So he can train because only one part of his body is injured. The rest of the body is very healthy. So you can do a lot of things. You can do conditioning programs for him, upper body, when the leg is injured, and maybe the left leg is injured, the right leg is still healthy. So you can do a lot of things. And these 2 days, we want to show you how to do this. Yeah, and I'm really looking forward, and I hope we have a great time. And I don't want to talk so much today. I give over to my good friend, Dr. Chan, and you enjoy the first hour with him. Thank you. Okay.
Okay. Good morning, everybody. Great pleasure to be invited to this program, and I would like to thank Ms. Riaz and Mr. Riaz and the ADC and Joerg for participating in this program, and I hope I can contribute to some of the information that you guys may find it useful here. I'm also the Vice President of the Asian Federation of Sports Medicine and the Vice President of Malaysian Association of Sports Medicine. I would like you all, I gather that there's people from various countries here. I would like you all to participate in the Asian Federation of Sports Medicine. If you have a national sports organization, I would like you to contact me through your or through your national organization through ASM to join together as a group, and then we can communicate and do more of these courses, which is more fitting to our Asian region. Okay, there are lots of things we can do together, and I think we should do that, and also great opportunities for research in the future as well. So without further ado, let me just move on to the lecture. Let me set this up on share screen. Just bear with me a few minutes. Can you guys see the screen? Is that good? Okay,
it's clear.
Great. Excellent. Right. So without further ado, the talk today is about athletic sports injuries, and it is actually a very, very big topic. So what I thought I'd do is maybe perhaps make it a little bit restricted to a few topics because of time, and maybe you can cover the rest of the topics in the future. So as you can see, sports injuries cover soft tissues, shoulders, joints, knees, ankle, foot, and there's a whole gamut of injuries. So in view of the time, I would just cluster all of them together like soft tissue injuries, and we'll talk about that first, and then we'll move on to some of the other topics. So maybe a good start is define what is injury. Injury is a failure of any body structure due to overloading, all right? And it's due to excessive transfer of energy. And it's a biomechanical phenomenon. And how the injury respond depends on the morphology, which means the bone, the ligaments, the tendon. And each of them have its maximal loading capacity and can be modulated by age, sex, and also the amount of forces and the rate and the direction and the duration that's acting on these tissues. And also, don't forget, biological tissues have an intrinsic viscoelastic property, which is quite unique. And some of this can be modulated. And training is very important. Training will increase the strength of the tissues, and disuse or will cause atrophy to a lot of these tissues and would add to more of the injuries. And also, it's also important to remember that the local injury mechanism can determine the outcome from a combination of external and internal factors. For example, in the ACL injury, the angle of the knee, the motion, and the ground reaction forces can all cause a damage in that extent. Another term that is perhaps also important to realize what is strain and what is strain. There's a lot of confusion in some areas. Strain is a biomechanical term, which I'm sure you guys are very familiar with, and it's a relative change of the length of the original tissue when the force is applied, and then the tissues change in length, and that you need to do it as a percentage of the difference in length as a percentage of the total original length, and that gives you a figure. All right, and a lot of these tissues can undergo a lot of strain before it fails, and if it goes beyond a physiological limit, then it will actually tear or result in micro tears or persistent injury, and that can lead to a chronic injury itself. When we say sprain, however, when we talk about sprain, it's usually applied to the clinical setting, where it is injury to ligaments and joint capsules and soft tissues that connects to bone and all this sort of thing. Okay, what are the signs and symptoms of any acute injuries, of these soft tissue injuries? Well, most of them is caused by trauma, obviously, in the athletic area. And they will have pain, swelling, instability, bruising, tenderness, and obviously stretch pain. And due to the pain, there's loss of function. And you can grade a lot of these sprains as grade 1, grade 2, grade 3, as indicated here, from mild tear to incomplete tear, with some looseness of the joint to a complete tear, ruptured ligaments to cause joint instability. That's a good classification for ligaments. However, the classification for muscle injury is not very well defined, and it's a lot of controversy involved at the moment. As you can see, the muscles can be damaged from myofibrils to bundles to secondary bundles or a macroscopic tear. But for clinical purpose, it's difficult to define for research, but still, we do need to treat these people as a group in that sense. So, for example, in the hamstrings, quite often you can see a lot of injuries, and it can be injuries from the attachment of the hamstrings along the ischial tuberosity at the where the back of the inferior aspect of the pelvis. And this is very common, particularly in young children or adolescents who are still growing. There's a physeal area, the area that the bone is still growing, where the cartilage is attached. And then that's the tendon that's attached over the physis there, and then it gets pulled due to a weakness in the area, and it can cause a lot of pain. It's one of the causes for hamstring injuries as well, and it can present like that. Or alternatively, they can tear in the middle of the muscle, as shown here on the right side of the image with the MRIs, right? And sometimes in a more adult situation, it can actually completely detach from the ischial tuberosity, and it will then contract to a shortened area with a bit of blood and hematoma that can be seen clearly in this white ring where the blood is on the MRI. And these need surgical treatment if they are top-flight athletes. Now, the intramuscular test, however, is a little bit more difficult to treat, partly because you cannot stitch muscles. It doesn't work. But there are lots of biological things that we are talking about now, like the PRPs, the growth factors, and all these sort of things. The idea is to stimulate muscle replacement, not with scar tissue, but with muscle fibers, so that it allows the athlete to maintain their competitive edge in that sense. The other area that a lot of athletes can get injured is around the groin. As you can see on the left side of the screen, there's a whole list of conditions that can present with groin pain. So it is sometimes quite difficult to figure out what's happening. So it needs a thorough history and examination, and a good idea of the anatomy around that area to figure out which of these are the cause of the pain in the groin. More interesting for me, this is a coming area that is probably not mentioned before in the past, is the hip pain, which is a common cause for, increasingly more recognized as a cause for pain in the groin. This is to do with femoral acetabular impingement. This is not such a good new concept. It's been around for 10 years or more when people became more and more aware with arthroscopy how these contribute to the pain in the hip and the front. Essentially, what's happening is that the acetabulum is like a socket, and the femoral head is like a ball. In a normal anatomy, you can see the head attaches to the neck, and that's kind of like a shoulder and a gap. And this allows for the movement of the acetabulum into the area of the neck without causing any impingement. But some athletes, especially I think in Caucasians, we see more of that, is that they have what we call a pistol grip deformity on the femoral neck. You can see on the right side of this image here, you can see that neck is rather like a slope without a kind of like a divot here to allow for the acetabulum to move into when the hip is abducted. Yeah, so that can cause pain in the front of the hip. And this is something we may have to look into a little bit more carefully in the future with patients presenting with groin pain. So how do we manage all these pains and strains? I'm sure most of you guys know, price, pain control, R for rest, I for ice, C for compression, and E for elevation. And it's quite important to do all this early to enable the return to function quickly. So to control pain, you can give non-steroidal anti-inflammatories, things like ibuprofen, Voltaren, and all this sort of thing, or even aspirins. But the more newer versions of these medications are the COX-2s like Arcoxia and Celebrex. They're very useful. And it's often very important to remember these are painkillers, but the primary function is to stop inflammation, which then stops pain. Panadol, morphine, and all this stops pain, but has no effect on inflammation. So quite often we have to remind our patients when we give these medication that they are to stop the inflammation and the pain. And by doing that, hopefully we'll get back to function quickly and prevents wasting and reduces the stress. And also more importantly, to prevent chronic pain syndrome. If it goes on for too long, chronic pain syndrome itself is very difficult to treat. And obviously rest is very important. It prevents secondary injury and it reduces the metabolism of the injured part so that it recovers. Ice is a very simple thing and very effective. It reduces pain, reduces the swelling, reduces the stiffness, and more importantly, it reduces the metabolic requirements and allows for early recovery. The other point that's quite often forgotten is that there should be no direct contact of the ice to the skin. Quite often we see in the clinical situation is that a lot of patients will just leave the ice bag on the knee and they leave it for like long periods of time, and it actually induces ice burn on the skin. All right, so what you want is a piece of cloth that allows fluid to be absorbed. So what you want is cold and dry, not cold and wet, and it needs to be moved every 15 minutes or so to prevent this sort of issues. And compression is very important. You need to support the injured part, and more importantly, by providing support, it immobilizes the joint and allows things to heal. And by not moving it too much, it also reduces the swelling and the muscle spasms, which then reduces the pain. Elevation is another very simple, effective way of controlling the swelling. And it's important to remember that you need to elevate the injured part to the horizontal level of the heart. This is to reduce the swelling by improving the venous return. The blood flowing out to the limb then flows back easily, and it will reduce the inflammation from that respect, and also reduces the pain, and often also reduces the stiffness. And it's important to know that the magic number in soft tissue injuries is 6 weeks. Anything that goes beyond 6 weeks with persistent pain, then you should seek medical advice soon, and to prevent any long-term repercussions as a result. Moving on to shoulder instability, that's another big area. So what I thought I'll pick a few, the common ones. Common conditions that affect particularly athletes is a dislocation of shoulders. But to understand that, one needs to be aware that there's such a thing as laxity and also instability. Laxity means it's a necessary attribute of the capture of the ligaments to the shoulder, and it allows the normal range of motion to the joint. This is the most mobile joint in your body. And instability means that they start developing pain and symptoms, as when you move the head, the humeral head, and the glenoid during active range of motion. So if that's the case, then we call it instability, and that needs to be treated. What produces or affords stability in the shoulder is very different from what affords stability in the lower limbs. In the shoulder, most of the support is actually from soft tissues. As you can see here in the shoulder, the scapula, the area of the glenoid compared to the humeral head is very, very small. It's only like 20% in contact. So the body actually has different means of trying to make it more stable by angulating the glenoid a bit upwards and more forwards, so that it faces forwards and upwards to support the humeral head. And the humeral head itself is also angulated 45 degrees up and backwards. And as a result, the scapula also is slightly tilted upwards towards the sky. More importantly, in the glenoid, there is a fibrocartilage ring, which is called the labrum, here in this diagram. And you can see that it actually deepens the socket quite a bit. Right? It is this labrum that is very, very important. And these labrum will have attachment of these ligaments. Yeah, these are thickenings and condensation of tissues around the glenohumeral joint. There's quite a few of them, the superior, the middle, and the inferior. And these form like check rings, like ropes, to provide stability of the glenoid from dislocating. And more importantly, it functions like a hammer to cradles the head and allows the humeral head to move in different directions, particularly in the ABR position, the abducted external rotated position, as you can see in this image here on the right. And this provides stability and stops the humeral head from falling out at the anterior inferior aspect of the glenohumeral joint. Once the humeral head dislocates, most of the time it dislocates through the front. And as you can see at the front, there are very important things running just in front of the glenohumeral joint. There are blood vessels, and there are major nerves and major veins. So you could imagine here, if this head falls out, it will compress on the blood vessel here, and it can cause damage, circulation problems, and also even nerve issues if it's not treated early. So any dislocation of the shoulder needs to be treated soon and not to be left for too long. Late presentation makes it very difficult to put it back, and also creates a lot of complications. Once the head falls out, this is the view from the axilla shooting up to the head. You can see this is the coracoid on the front, this is the acromion at the back, and this is the humeral head, and this is the glenoid. The axillary view and the X-ray will show you very well whether the head actually falls out through the front or through the back. When it falls out through the front, the corner, the anterior inferior corner of the glenoid can sometimes cause a divot, a damage, a compression fracture to the humeral head. And as a result, if it is as big as this here in this image, when the humeral head rotates, it can actually fall out, and that glenoid will catch this area, and the whole humeral head can get locked and jammed. Like in this view, you can imagine that this fellow actually extends the
306A.
The glenoid will engage over this fracture. So these are too big to be treated with arthroscopic surgery, and it may need a bone graft to fill up that defect. This is on the humeral side. Okay. Now on the glenoid side, the shoulder instability can also can be graded in terms of traumatic or atraumatic. But you need to understand that there is actually a gradation, a continuum from very stiff shoulders in some athletes to very, very loose shoulders in others. And it's certain sports that requires certain types of laxity to have the edge. So laxity itself is not a problem, but when they have pain, then it becomes an issue. And that's where we have to address and treat. And once it dislocates, it needs to be put back. And shoulder dislocation has been around since the Egyptian times. You know, we can see in the hieroglyphics. But the simplest and safest way to put it back is by gentle traction, about 45 degrees away from the patient in the vertical, and with counter traction on the opposite side to push it back. Do not do the cocker maneuver, which is the traditional old-fashioned way of doing it. Which means you pull the humerus in this direction, but you external rotate, and then you AD move the shoulder elbow to the midline, and then you internally rotate. The problem with that is that if it's not properly reduced, there's a real chance you will fracture the neck of the humerus, which then makes things 10 times more difficult for the surgeon to fix. Okay. And there are lots of tests you can do to ascertain the stability. I don't know what's happened to my image here. Okay, never mind. This is a test. We call it the drawer test. You can see this is very, very unstable. This head is slopping front and back in the glenohumeral joint. And you can see when he pulls the arm, there's a sulcus sign, that the sort of indentation of the soft tissue around here due to the negative suction effect of the glenoid when it is being sort of dragged down. And during the operation, one can also do some tests to see how stable they are by applying a vertical loading, and then you dislocate the humerus and then push it back by adducting. It goes in and then it's out and it's in again. So this is how the humeral head dislocates and damages the glenoid. So this is the position we put the patient usually on the side. And these are the camera portals, the holes that we put the cameras and the working instruments through the front. And this is what we do. What essentially is that there's a tear around this region where the glenoid completely gets ripped off. And what we do is you put all these little anchors and then you put stitches to reattach the glenoid. And also sometimes you take bites of this tissue of the capsule to tighten things up a bit. And this is what it looks like at the more microscopic level. And this is what happens when the glenoid, the humeral head dislocates and it rips off this fibrous ring. They call it the labrum. And the anchor itself is to tie this all back to where it was all intended. So this is a image where the humeral head is removed, and you can see once it dislocates, this is the area that's damaged. And if it's big enough, sometimes, unfortunately, a big chunk of the bone is also involved, and that makes it a very, very difficult situation. Then that requires a bone block to reattach. Either you reattach the bone or you take bone from somewhere to fill up that space, and then you reattach all this glenoid, the labrum, to the bone to provide stability. And these are just arthroscopic image. You can see the tear there. That's the anchor into the glenoid. And then the stitches, that's what happens when we tie them back. And you can see there's now a reattachment of the labrum and a bump that provides the stopper effect to the patient. Moving on to the next one is chromoclavicular joint injuries, which is a very common one, particularly with contact sports. But even running athletes do sometimes fall and can sustain this sort of injury. And they often present with pain. and it's often over the distal end of the clavicle here, and lying on the side is very painful, and there's loss of elevation, and the pain is particularly worse at the end range of elevation, forward flexion, and adduction. And occasionally you will see they may even have crepitus. Strength, however, is normal. All right, and this is the classification that's been used. And obviously, mild type 1 and type 2, we generally don't need to have any surgical intervention. Type 3 depends on the symptoms and the sports the athlete performs. For upper limb loading type of sports, then they probably have to talk about some sort of surgical intervention. And the more important one is the type 6. Remember, I said that there's the front here, there are blood vessels and nerves. If this clavicle actually dislocates and goes under the coracoid, it can damage blood vessels and nerves. This is quite a dangerous condition. So obviously, if it's this sort of thing, then surgical intervention is urgently needed. This is just another representation. So sometimes when the situation is so painful, and the ligaments are still intact, what we do is just remove the bone using keyhole surgery, like just now, using a burr to remove all these bones. And at the back of this bone here, which is the acromion, and this is the clavicle right at the back. And then we remove a little bit of the distal end of the clavicle and acromion, and that will stop the pain. It's called a Mumford procedure. It's a very simple procedure, and it works very well in controlling pain, and it affords normal movements. This is only adequate provided the ligaments are intact. But when these ligaments are damaged completely and is type 3 to 6, then you have to talk about reconstructing ligaments, or you can stabilize it in the acute setting with a screw. And in the chronic situation, you might want to talk about reconstructing these ligaments with hamstrings, autografts, or allografts, and tie them down with the bioabsorbable screws. And sometimes you can reinforce it with all these buttons. So that's the AC joint. Moving on to the rotator cuff injury. This is not so common in running sports, but it sometimes happens as a result of fall. It can be in young patients or older patients, and they often present with pain with overhead activities, and more importantly, weakness in lifting their arms up. And more importantly, night pain is the one that usually gets them. The pain never goes away, and it's always there at night and stops them from sleeping, and that's how they will usually present. And the position where they complain of the pain is around the humerus, the proximal humerus here, not here. When they complain of pain over this side, just over the shoulder, then you have to think about it may not necessarily be a rotator cuff tear. And quite often you can see there's wasting over the supraspinatus fossa, swelling over the anterior shoulder if there's a big hole with fluid leaking out from the glenohumeral joint. And the humeral head can be prominent anteriorly. And not uncommonly, you will also see a Popeye tendon rupture, biceps tendon rupture, and there's a Popeye muscle over the anterior aspect of the arm. And there's tenderness over the greater tuberosity and over the supraspinatus fossa. And of course, there's also tenderness over the AC joint, bicipital groove with loss of range of motion, and more importantly, weakness. They cannot resist elevation when you test them. And if they present late, then they will develop stiff shoulders because it's too painful, they haven't used it, and this is the end result. And on the MRI, you can see that, you know, there's a gap here. This is what a normal MRI looks like. There's continuity of the muscle with the tendon over the greater tuberosity. But over here, you can see there's a gap, and there's fluid from the humeral joint leaking out to the subacromial space through this gap. And then usually for athletes, you need to proceed with surgery, because without surgery, these supraspinatus muscle will waste. This is a normal supraspinatus fossa in the scapula. You can see this is wasted, and some of them can undergo fatty degeneration. And if that's the case, it's too late. The muscle may not return to what it was before. So early intervention, especially in an athlete, is important with rotator cuff tear in a young person. The idea of the rotator cuff is to balance the force so that the force couple is balanced and it can move and be controlled in the range of motion. And without that, they can get pain. The humeral head will not maintain itself in the middle of the socket in the glenoid, and it will translate upwards, forwards, backwards, everywhere, and that adds to the pain. So arthroscopically, through keyhole, we check, see whether these tendons can be pulled back to where it was intended. And if we can, then we usually would put a screw over the greater tuberosity. That's where the tear usually happens. And you can see that hole there. This is now looking from outside the glenohumeral joint in the subacromial space. You put an anchor in there, and then you put sutures, and then you tie these tendons back to where these sutures are through these anchors. Yeah. Let me just speed this up a bit. Okay, you can see the sutures, the stitches, and then we then pass it through the tendon and then reattach it. So the other alternative way of doing it is the old-fashioned way without keyhole surgery, is to make a big incision. Then you make multiple drill holes through the bone and then reattach the sutures and then tie this tendon back to where it was intended. With these screws, life is a lot easier, and it can be done keyhole-wise. You can see before and then the after image where the tendons are now reattached. And this usually gets rid of that pain, and then it takes about 6 to 8 weeks to heal, and then they need proper rehabilitation and strength training only after 8 weeks onwards. Yeah. So, and this is what it looks like on the x-rays with these metallic anchors. These are the old-fashioned ones. Nowadays we use plastics, so you can't see them, and it doesn't beep when you go to the airport. Moving on to the lower limbs, we have ACL injuries, which is a very, very common thing in a lot of athletes in the running sports and contact sports like football. It's important that a lot of animals have ACL. Human, cows, sheep, goat, pigs, dogs, and even rabbits. And they all have 2 ligaments, in fact. The prominent 2, there's actually 3. The third one is the intermediate one, which is not very, very big. So it's not just a single structure. Like in this anatomical dissection, you can see the AM bundle, and then there's another PL bundle, and this is the PCL. This is with the knee flexed at 90 degrees, and you can see this. And you can see how it works very differently. This is the AM and the PL. You see an inflection, the PL now goes to the front, and it's quite high up to the AM, which originally started much higher. The reason for that is because it allows the knee to rotate in flexion. If they do not have this dual system, it's very difficult for the knee to rotate in flexion, and you need some degree of rotation to have efficient motion of your knee to propel yourself forwards in running and jumping sports. And quite often it can get injured, like what happens here in this badminton player. You can look at the left knee, that's how she does it. So she lands on the jumping part is the easy part. It's usually the landing part, and particularly in girls, and you can see that her hips, her knees are in valgus, and when they jump, they land in valgus, external rotated, and the femur is internal rotated on the tibia, and that's how they get it, sustain this injury. And tests like the Lachman test shown here is very, very pathognomonic of a ACL tear. If you can get the knee to move like that, you can be sure it's an ACL is gone. And in a young athlete, you will want to talk about surgery. And the pivot shift is another test. And again, this is very specific test for ACL instability. And once, if you get these 2 signs, it is almost certainly the ACL is gone and it needs to be fixed in a young person and athlete. Conservative treatment is not very helpful. It's important also to realize that these 2 bundles actually sit in different areas in the femur and the tibia. And that's because on anatomical dissection, you can see on the tibial surface, the PL and the AM is very, very big. And that's what we try to replicate. You can see it on the MRI. You got 2 bundles, okay? AM and PL. What we try to do now is to replicate this with a surgery that is the double bundle technique, which I will mention in a minute. This is an MRI showing a complete tear of the ACL, where the bundle now has completely fallen down from the attachment at the femur aspect on the lateral view. And you can see a lot of swelling, and you can see the tibia is relatively translated anterior relative to the femur in this view. So how do we fix this? Well, we do it this way, with one leg up and one leg down. This is the operated side, through little keyholes. The way we harvest the autograft is through a little separate incision here at the proximal tibia. We take the semitendinosus and the gracilis from here, and then we will pass through drill holes on the femur and the tibia and pass it through and fix it with screws. Okay, as you can see, we're trying to replicate the two different angles which the ACL has to the double bundles, so that they will replicate what God intended in that sense. So these are just operative images showing how it's done with two separate wires, with two separate tunnels. This may not be possible in all patients, and sometimes the patients are too small, then technically it is not feasible, in which case then a single tunnel may be the only option. But it's not the end of the world. This double bundle technique is still a little bit controversial, as some people think that it doesn't contribute a lot more to stability. But my impression, and I've been doing this for the past 6 years, it gives a better range of motion and stability in all the different angles of flexion of the knee. These are the operative images showing the two tunnels on the femur side. As the graph's been put in, you can see when you test in flexion, this AM is tight, the PL is loose. But when you do it in extension, you can see now the two bundles now become parallel, and the more extension there is, you can see now it overlaps each other, and when you pull, the PL now is stiff. We secure these grafts with all these metal buttons and biodissolvable screws inside the tunnel to provide stability and incorporation of the graft inside the tunnel. And the incorporation can take up to 9 months with hamstrings. For VTB, you can accelerate your rehab and return to sports, perhaps up to 6 months. But in general, the ligaments still undergoes a lot of biological changes. And these are the final x-rays you can see with the two little buttons, two separate tunnels on the femur side, and then tibial side, there are two separate tunnels with two separate dissolvable screws here. Quite often associated with the ACL tear, the meniscal tear. Patients can present with a history of twisting in the knee, and they feel a clunk and a click at the time. And after that, they are unable to continue running or playing their sports. Swelling can be immediate, or it can progress slowly over the next few weeks, and they have difficulty weight bearing. And more importantly, they cannot squat. All right. And when you test the knee is actually stable. There may be intermittent locking and stiffness, and that usually gives you some idea this is a meniscal problem, because it's a mechanical thing that is loose, that is moving in and out of the joint and locking it. And this causes them a pain, and then the knee gives way intermittently. And when you examine them, they may have a lot of fluid effusion in the knee, and in a delayed presentation, they may have a lot of wasting. And when the knee is a bit stuck, they can have 5 degrees of fixed flexion, and they may also lose the last 10 degrees of full flexion. And obviously, when you do the ACL test, the Lachman, the pivot chip, all this is all pretty normal. The McMurray's test is quite helpful, but it is not a very sensitive or specific test. Still, it's worthwhile doing it, and the technique is to put your thumb and your index finger along the joint line, and you apply a rotational force with a bit of valgus stress and varus stress as you go into full extension. And quite often you can feel either a click or pain over the lateral or the medial aspect of the joint that will give you some idea where the location of the tear is. And the meniscus itself is a relatively avascular structure. It sits between the femur and the tibia over here. As you can see in this stained image, the blood supply is really at the periphery. On the inner third, there's hardly any blood supply. So once the meniscus is torn, it doesn't actually heal. And the reason is that because the blood supply is so poor, And you can divide this into the inner third, the middle third, or the outer third. Those at the outer third or the middle junction between the middle third or outer third, those are the best ones to heal with stitching. Those with the inner third or inner part of the junction between middle third and middle third or inner third, those cannot usually be fixed, and in the sense that we don't usually suture those, and it's also very small, so we would normally remove that bit. Much of it is, much of the meniscus is damaged, mainly at the back. As you can see, you need to do a knee roll back before you can actually flex your knee more than 108, more than 90 degrees. Because if the knee does not roll back, then there's no way people would be able to squat. So by virtue of the way the anatomy and the ligaments function, it will have to roll back. And when it rolls back, it sometimes traps the meniscus at the back, and it gets squashed between the femur and the tibia, and that's how the meniscal tear happens most of the time. So in the acute setting, price, as you say, pain, rest, ice, compression, and elevation is important. And once it's resolved and there's no flexion deformity, then usually they can function back to its normal. Then we generally leave it alone. But physiotherapy is important to prevent any muscle wasting and stiffness of the knee. But if the knee is locked, like there's a 5-10 degrees fixed flexion deformity or loss of full flexion, then surgery is almost certainly required. And there's persistent pain and swelling. That's another indication for meniscal surgery as well. The tear pattern can be various patterns as shown here in the left side. It can be a longitudinal tear. If it slips inside into the center of the joint, it can be a displaced bucket handle, or it can be a parabead tear like that, and a displaced flap which rotated 180 degrees on itself, or a radial tear like that. And you get a complex one, which makes life very difficult, and it may not be stitchable, or an incomplete tear where it tears only on the top surface or the undersurface. And when there's a big bucket tear, it sometimes can lock the knee because this part has now slipped into the center of the joint, and it blocks the knee from full extension. These are operative images showing a flap tear that has rotated. This is at the back of the knee. The round ball on the top is the femur, and the flat surface on the bottom is the tibia. And this is the lateral side. You can see there's a very big tear. It's very, very loose. And this is what we mean by this meniscus slipping inside and jamming the knee. And that's how we fix this with stitches and the junction of the meniscal capsular junction and the middle third of the meniscus with these non-dissolvable stitches to provide stability and prevent locking. If these are not treated long-term, the articular surface of the cartilage on the femur or on the tibia will get damaged, like you can see here. They can actually cause a lot of gouging out damage, and bits and pieces of the cartilage will fall out, and eventually the athlete will develop osteoarthritis. So that's one of the major indications for trying to fix this early. If you leave it for too long, more chondral damage can occur. And these are the operative images. That's how we do. We put a stitch in, and then the stitches, you then pull, and then you can cut the stitches off. Once it's done, you can see it's quite stable. You put multiple stitches, and after that you probe it with a hook, and then the meniscus is very stable and doesn't cause any further problems. And the hope is that the meniscal capsular junction will heal with scarring and provide stability to the meniscal tear. Moving on to the chondral injury, you can see that if it's not treated, all these bits and pieces will fall off, and it will be acting like more stone pebbles inside the knee joint, causing more damage and more arthritis. And when it's completely down to bone, sometimes what we do is we drill multiple holes to encourage blood and bleeding and stem cells from inside the bone marrow to come up to fill up that space. It's useful to do that, but the results are not long-term satisfactory in that sense. It will last, but up to 2 years, and this is one of our holy grails in orthopedic surgery, trying to fix this, trying to figure out what to do. And the next most common thing is a patellar instability. These are often in females and young ladies with anterior knee pain. They present with apprehension and on twisting and difficulty climbing stairs. And quite often they have poor muscle control, the quads are wasted, and they also have a very high Q angle and external tibial torsion of the femur, tibia, and also femoral neck anteversion. These needs to be looked at carefully. And this group of patients with patellar instability is very difficult to treat and difficult to diagnose the cause for this problem. And all this imaging is very important because you can help to show how shallow the trochlear groove is, and from there you can plan your surgery. Generalized laxity is another additional factor that needs to be looked at. So X-rays is a basic baseline, and then MRI is very important. Non-operative treatment requires physiotherapy and non-steroidal anti-inflammatories for pain control. If that fails, then stabilization procedures needs to be considered. It can be bony procedures, soft tissue procedures, or soft tissue reconstruction procedures like the MPFL reconstruction, which is now more and more favored in that sense. And when you do an MRI or X-ray, you can see what happens sometimes when the patella dislocates. It can actually take a fragment of the articular surface of the retropatellar surface with a fracture fragment coming off, or it can fracture the lateral aspect of the lateral femur condyle over the anterior aspect. And then that little piece can float inside the joint and cause jamming and locking. And also, there's also bone swelling of the lateral femoral condyle, and obviously a lot of bleeding as well. So this is now the current favorite mode of treatment, is to reconstruct the MPFL, and may or may not include a lateral release from inside the capsule, so that the patella now will remain in the right position. Ankle injuries is another area that's very, very common, particularly with running sports. And to start off with, we talk about Achilles tendon. Achilles tendon is a common injury. It can occur in an acute setting or chronic setting. In this acute setting, they may have sudden onset of pain. They may even hear a snap noise, and then there's completely loss of power, and they cannot continue running, and there'll be severe pain. But in the chronic situation, they have pain after running, and it doesn't go away, and eventually they form scarring and a palpable lump at the back of the Achilles tendon. In the acute setting, on examination, you'll see there's bruising, swelling, tenderness, and the Thompson's test is positive. The Thompson's test involves lying the patient prone and squeezing the calf. And if you squeeze the calf, the ankle does not plantar flex. That means there's a discontinuity of the Achilles tendon. And when you palpate, there's actually a gap in the Achilles tendon, which doesn't, that will cause the Achilles tendon to be painful and also unable to plantar flex with any great amount of strength. MRI ultrasound is very useful to diagnose this. The non-operative meat treatment is put them in a cast or walking boot with a foot plantar flex, but usually for an athlete, surgery would be a better option. It can be done through a small incision or through a large incision. Now, the MRIs are very, very important in this situation because you can differentiate, different aspects of where the tear is and the pathology is. And in the tendinosis situation, where these are chronic, they have multiple repeated injuries, but small enough to cause the pain, but not big enough to cause a tear. And eventually they will undergo changes inside, and it can be gelatinous type of material, and it can be quite extensive. Eventually the Achilles tendon will weaken because it's like a hollow in the cylinder, and it may snap. Quite often it will snap in the upper, just about 1 or 2 inches over the calcaneus, right at that junction. Or occasionally it can actually avulse and tear from the insertion. So how the tear occurs will determine what we need to do to repair it. And obviously non-operative treatment is quite important when to prevent this sort of thing. So once they heal up in the acute setting, if there's no complete tear, is to rehabilitate them with a eccentric sort of rehabilitation program for the Achilles tendon. For complete tear, you can see that there's discontinuity of the tendon. This is the proximal end, this is the distal end, this is a mid-substance tear. And normally we would be pulling it out and then passing sutures and then tying it up. For the insertional avulsion tears, normally we will put suture anchors with like the ones in the rotator cuff, and then we have these sutures to tie this back down to where it was supposed to be, and that usually will help to solve the problem. Moving on to the next one, the ankle sprains, which is extremely common in running athletes and jumping athletes, are injuries around the anterior talofibular ligament and the calcaneofibular ligament. And as we said, the grading can be 1, 2, 3, depending on the extent of the tear. And these are the two ligaments. If you tear the anterior talofibular ligament with the calcaneofibular ligament intact, then you may get away without operative treatment. But if both these two ligaments are torn, then surgical intervention is almost certainly required. And the mechanism of injury is this supination injury with the foot in this position. The inversion. Eversion injury is not so common. If it's eversion, then the deltoid on the medial side, the ligaments on the medial side is the one that gets hit. And on a high ankle sprain, where the foot is plantar and there's a rotation, so the tear may occur higher up, not the ATFL, but the syndesmotic ligament up further up on the tibiofibular joint. In the acute situation, you can see bruising, a lot of swelling and pain, and the best way to treat it is to ice it, rest it, and support it with a bandage. Even a ankle stirrup would be helpful, but in a very more severe situation, the boot will be more comfortable, and then they need to wear this for most of the time to see if that helps to heal. And if it doesn't heal at 6 weeks, then you have to consider surgery as a necessary option. And these are the tests that one could do. You do an anterior drawer test. You should also do a tailor tilt test, and this can be done under stress views in X-ray department. And you apply the stress, you can see this opening of this gap on the lateral side of the tibio-talar joint. And the suction sign here, when you do the anterior drawer test, there's just like in the sulcus sign in the shoulder, there's an indentation due to the negative pressure effect of the joint being pulled forward. We can see even on the X-ray, there's a gap there posteriorly when stressed. This is one of the cases I've done. You can see it translates forwards with the draw test a lot, yeah. And this is compared to the normal side, it doesn't move at all. That's a pre-op. Sorry, and this is post-op. Once we fix it with the rostrum repair, you can see it doesn't move very much now. All right, and then this is just a normal side, so it's well within the normal range. That's what we want to do. We don't want to over tighten things, and certainly don't want to keep it too loose. So the rostrum repair is a reattachment of all these ligaments, and then reinforcing it with the retinaculum here. Okay. The way we do it is normally to put a suture anchor over the anterior distal fibula here, and another anchor for the calcaneofibular ligament, and that would help to tie these ligaments back, and then you reinforce it with the retinaculum. Other alternatives, the old-fashioned way to do it is to use the peroneal brevis tendon and then do a kind of a loop. The not so good part of this is that this stiffens the subtalar joint too extensively, and it's not very good for athletes to be too stiff with the subtalar joint, particularly with running and jumping sports. They will have pain in the subtalar joint and perhaps even arthritis at the later stage. We're nearly to the end now, so stress fracture. Stress fracture is very common in people who do a lot of running and jumping. It's due to repetitive trauma, and it can have a localized swelling and pain on weight bearing. Investigations involve X-rays and MRIs, and when it's not very clear, then even a bone scan is very helpful to see where the issue is. Initially, non-operative treatment would be the best if it's not too displaced, and usually it should not be displaced because these are very like hairline fractures that sometimes is very difficult to spot, and that's why the bone scan is quite helpful. So you need to rest it, and if necessary, put a plaster of Paris, and then you need to offload the foot to let it rest. And in situations where they run into non-union or displacement of the fracture or pain in spite of non-operative treatment, then surgical treatment may be necessary. As you can see here on the x-ray here, there's a stress fracture at the base of the fifth toe, and it's failed to heal, and sometimes you may have to put wires to hold things together and then compress it to allow healing to happen. Don't forget, you can get a similar situation over the sesamoid, and there can be pain over the plantar aspect of the big toe, particularly when you dorsiflex, and these to do with runners who end up with a lot of pain. And these fractures can involve many other joints. Tibia is the next most common area, the proximal shaft or the mid shaft, and sometimes it's difficult to tell, and that's where the bone scan is useful. And if it's usually they don't need surgical intervention, but just rest. Yeah. And the duration for healing varies, which depends on which bone. On the femur, it takes about 12 weeks. The femur, tibia also about 12 weeks. The metatarsal about 4 weeks, and that kind of thing. All right. So the toes will certainly be a lot faster, and the femur and the tibia usually a lot longer because it takes a lot of stress and pressure. And if they present late, you can see the callus forming over the very hairline kind of fracture area, which is very common over the metatarsal in the foot, in this case in the third one, and this one on the fourth toe. And these are the things that you can see. I think I've come to the end of my talk. I hope I haven't bombarded you guys with too much information, but if you need any further clarification, delighted to hang around to see if you guys want any questions, to answer any questions. Yeah. Okay.
There we are.
Right.
You go in the middle.
Right. Are there any questions? Oops.
Not yet.
Oh, okay. All right.
No, and that's for Maria.
Okay, right. Are there any questions from anybody to clarify anything?
Hello, my name is Ali and I'm from Pakistan. So my question is regarding about the ligament injury. So especially as you mentioned, like when there is like grade 1 and grade 2 injury, we can put cast or any bracing or any like to immobilize the joint. So my question in that regard, what is an ideal time frame to keep that cast and bracing to heal ligament properly, and what is the approximate duration of that grade 1 and grade 2 ligament healing?
I think the healing time, it can be can vary quite a bit depending on the extent of the injury. As a general rule, you should treat it like a fracture. For around the lower limbs, it takes about 6 weeks. As we said, 6 weeks is the magic number. Yeah. And immobilization should be the very minimum 4 weeks, and then you reassess. If there's no swelling, there's not much pain, you can start early rehab, gentle range of motion. Don't go to the extremes. The idea is to maintain the muscles in good shape, but not necessarily stressing the ligament that is trying to heal. And you still need to protect it for a further 2 weeks. And usually I will wait after 6 weeks. Then if there's no pain, then I will go full blast, full range of motion, full strengthening program, and then escalate from there to the sport specific program later on. Does that answer your question?
Yeah, thank you.
Good morning, Dr. Chan.
Hi.
I'm Raj Mohan from India.
Yeah.
I just want to clarify one thing regarding the calcaneum spur. Is it a very situation that we have to remove that calcaneum spur for an athletic person? The
you mean at the plantar aspect, is it?
Plantar, yes. Yeah.
Okay, I see a lot of this. Actually, if you look carefully, the calcaneal spur is not the cause. A lot of people get this impression that the spur is the problem. It's actually a response to tibialis posterior tendon weakness. because the tibialis posterior tendon actually maintains your medial aspect of your arch in the foot. So as the tibialis posterior weakens over time, the arch flattens out. And when it flattens out, it will pull the plantar fascia that's attached over the calcaneal spur region. And over a long period of time, the bone will respond by growing longer and longer. So to me, the calcaneal spur is very rarely a problem. In my entire career, I've only probably operated on one patient. But almost always, you need to check the tibialis posterior tendon. That is the cause. And it's actually part of the tibialis posterior tendon dysfunction syndrome, I would call it. You also need to lengthen, stretch out the Achilles tendon, which is often another cause for this problem. Because if your tibialis posterior is weak, your hind foot will go into valgus. When it goes into valgus, the Achilles tendon is never stretched. And once it's left in that position for too long, now the tibialis posterior cannot win. It cannot pull the hind foot back into varus. Yeah, and as a result, it causes stiffness as well to the dorsiflexion of your ankle, and which compounds the problem. So I would suggest you look at the tibialis posterior carefully and examine them, test them for strength, coordination as well. One simple way I would normally do it is get them to stand on tiptoe, and you do like the Trendelenburg test. You ask them to put their hands on your hand, tiptoe, and then take one leg off the foot, the good one, the symptomatic one off the foot first, so that they stand on one single heel raise on the asymptomatic side to get a feel that, how strong they are. Then you get them to stand on the symptomatic side with one foot, and you can see they will sway all over the place and they will get pain. So that's one rough estimate, how good the tibialis posterior tendon is. And from there, you have to address the appropriate rehabilitation program and that sort of thing. Yeah.
Thank you very much, sir. Thank you. Thanks a lot.
Yeah. Anything else? Good. Well, I'll hand over to Joerg.
First of all, thank you very much, Dr. Teichmann. Pleasure, Sunday morning, to come over here.
Thank you.
I guess we have a 5 minutes break. Yeah, catch a drink, and then I see you in 5 minutes. Yes. Okay? All right. Thank you.
Thank you, guys. Nice meeting you all. Okay. Cheers. Thank you, Ria and Miss Ria.
Thank you, Dr. Chan.
Thanks. Bye-bye.
Thank you, Doctor.